Okay, when we bring you in from out of town, we like to make you work really hard. So Dr. Mehran's going to come back, and she's going to talk about management of coronary artery disease and TAVR. We apologize for the construction noise. They're actually installing a 7 Tesla magnet downstairs, and so unfortunately that's going to happen intermittently.
It's good you have a loud New Yorker coming right over all of this,
about
and
Neal?
you know, getting ready for the Yankee Red Sox game tonight. So there we go. Okay, so now the next topic, an important topic, CAD and TAVR. My disclosures haven't changed from a minute ago, except you should know I perform coronary interventions for sure. So the prevalence of CAD increases with age. Wow, I think you all know that. And TAVR is a disease of the elderly. I mean, aortic stenosis is an elderly population, and so therefore the prevalence and the prevalence of CAD in patients undergoing TAVR with aortic stenosis obviously is tremendous, as high as 80% in some series, and you can take a look, it's at least 50 to 80% of the patients who will come to you with aortic stenosis will have some coronary artery disease. And a lot of this has to do with the fact that there are shared risk factors in the pathophysiological mechanisms of both plaque formation in the coronary arteries and plaque formation around the aortic valve. And so the calcific aortic stenosis also has to do with mechanical stress, endothelial damage, lipid deposition, and local inflammation. All of those things that are happening in a micro level in the coronary arteries are happening, unfortunately, in the entire aorta, specifically in the aortic valve, especially because of the mechanical stress. I want to just share with you a case that we did and what are some of the dilemmas. This is a patient who came a few years back with 94 years old, severe aortic stenosis, and came with a lot of fatigue and dyspnea. Here's the echo finding, the annular size. You see this woman with a small annular size of 22, aortic valve area of 0.4, so severe, significant aortic stenosis with a mean gradient of 48. But here's what I left it sort of running without dye, so you can see the entire artery. And this is not something that is rare. This is what we're seeing in a lot of these patients. Severe, significant calcific disease that could be correlating to her also in combination with severe aortic stenosis, I mean, with a valve area of 0.4. So what's a girl to do? Because we get to decide what to do here. And obviously the hemodynamics show severe aortic stenosis and comply with exactly what the hemodynamics showed. We did a CT angiogram. We took the patient right off the table. A heart valve team has to be evaluated. We knew about the aortic stenosis beforehand, but when you see that significant coronary, 3-vessel coronary disease, there really needs to be a good discussion and good planning of the case. That's the first and most important lesson. And so we looked at the CT angiography, we calculated an STS risk score, Euro score, and you see that it's a high-risk patient. In fact, surgical AVR was basically denied, and at that time we didn't have even the ability to do this yet. It wasn't yet approved fully, but the heart team made the decision altogether that this is a great case for TAVR, but that the coronary disease needed to also be addressed. But in order to get forward with the coronary intervention, what we did do first is a balloon aortic valvuloplasty. Now, there's no guideline to tell you how to proceed with these cases, but here we did that and proceeded to take care of the LAD and as well as the right coronary artery, and then proceeded with a core valve placement, and this patient did well. She's 94 years old. That was 4 years ago. She's since passed from a a malignancy, actually. So she really, her aortic, she had another 2.5 years of really good quality of life after this TAVR procedure, which was, she would have not obviously done well otherwise. The gold standard of how to make the diagnosis for anyone who comes in with aortic stenosis, whether they're going for surgery or TAVR, is to perform coronary angiogram. There's no AUC negative criteria for this. You should do a coronary angiogram, and in fact, in the AUC multimodality imaging, we gave this a high, absolutely appropriate thing to do. But there is a value of CT angiogram in some of these patients. This is a single center study with only about 500 patients, but they did show that they were able to evaluate patients, and they didn't find a clinical outcome difference with CTA versus coronary angiography for evaluation and diagnosis of CAD and treatment of it. The impact of CAD on TAVR outcomes is something that's important to note. I think there's no question that obviously you think about if they have PCI versus if they don't, and I'm going to share some of those data. There are important conflicting data. This particular retrospective study of 663 patients shows no difference between those patients who had versus those who did not have CAD, who underwent TAVR. I would imagine that perhaps this may or may not be the case. It could be related to how significant the CAD is versus whether or not PCI is being performed. And at the end of the day, we have to think about the clinical judgment. This meta-analysis that includes that study plus 6 other studies with 2,400 patients corroborates the data that presence of CAD is not really a big risk factor. But actually, if you look at the very, very large, most recently, the largest series of patients from the burn TAVR and PCI registries, this single center study with 8,671 PCI procedures and 800 TAVR procedures looked at the patients who had TAVR and CAD versus those who had TAVR no CAD, TAVR CAD versus those patients who had CAD and no aortic stenosis, and then of course comparing the TAVR non-CAD patients with CAD and non-aortic stenosis patients. And if you actually take a look, the CAD alone patient population is down below here in purple. The patients with TAVR and CAD had the highest cardiovascular death, cardiovascular events, or myocardial infarction over a 1-year period. So here is a conflicting data from this registry that shows presence of CAD did have an important implication. In our WIN TAVR registry, which was a 1,000 patient registry of only women, yes, I performed studies a lot on women only. I thought it was important to kind of think about that. And one of the important risk factors was a prior PCI or CABG, so presence of CAD did have an important implication on the 1-year outcome of stroke or death. If you look at a recent meta-analysis, in most of the meta-analysis, CAD is associated with an outcome, a poor outcome after TAVR, and must be evaluated as such. And it is important to note that right now, we have a lot of discrepancies of the earlier data with not insufficient statistical power, different definitions of the severity of CAD, and of course, different management of CAD. What do you do with a patient who has CAD and TAVR? I really like this expert consensus by Steve Ramey. Before the TAVR, you have an evaluation with a coronary angiogram. If there is significant CAD, and we're going to basically kind of think about this side of the slide, significant CAD, you take a look and see, is there proximal or left main disease, like the patient I just showed, where there was a lot of proximal disease, especially the proximal LAD. If there is, you do PCI before or at the time of TAVR. if the PCI risk is not prohibitive. And I think it's important to think about that. If not, and that these vessels are, there's no left main or proximal disease, but there is some small vessel disease, but you're concerned that some of the patient's syndromes or symptoms are coming from CAD, then you should proceed with PCI and TAVR. But if not, you should then go forward with the TAVR and reassess the CAD later. It's a nice evaluation algorithm. It tells you how important the constant evaluation of patient risk, anatomical risk, and procedural risks are considered in making those important decisions going down the line. I think you could also think about this schematic that I put together for you and think about the pros and the cons of performing PCI before or combined or after the TAVR. Obviously, after the TAVR, there's a lot of cons because you really have to think about some of the issues of reaching and dealing with your, especially with different valve types, getting to your to where you need to treat the patient. The pros is that you are treating that severe aortic stenosis and your procedure should go well, but you have to make sure that you have good access to those coronary arteries. If you're combining it, there are a lot of pros, decreasing the risk of mortality and issues with TAVR, and a lot of the patients, and you saw what I did in our case with the severe CAD and aortic stenosis, severe aortic stenosis. We performed a balloon valvuloplasty first, proceeded with the PCI, and then brought the patient back a month later for their TAVR. You could do that as well. But remember that if you do everything in one sitting, you could have a increased dye load. Doing it before the TAVR, there are some important DAPT considerations that you have to kind of think about, and bleeding considerations around the TAVR procedure. And of course, the risk of doing a PCI in presence of severe, significant aortic stenosis, and a lot of operators will perform a balloon aortic valvuloplasty before proceeding. But certainly it is important to kind of think about that as well. What's the optimal timing of PCI in TAVR patients? I think it's important to note that whether or not you do a concomitant or staged PCI, what the staged PCI in my mind is probably better. And the reason for that is that you are probably reducing the contrast volume and renal related complications, as well as thinking about better how to manage important peri-procedural issues that have to do with a stent procedure versus a TAVR procedure. But you could see here from these meta-analyses that life-threatening bleed, access site complications, and 30-day mortality is no different if you do it one way or another. And at the end of the day, it's really the schematic of what I talked about that matters. What about the specific case of obstructing the left main? And it's very important to think about those patients from the left main TAVI international registry. It's very interesting that they found that you could do TAVR and left main PCI together, and it's feasible, and technically you're able to do this. Delayed coronary obstruction is a very rare, but it is a catastrophic complication that could occur after TAVR. With really excellent skills, you should be able to avoid this in 99% of your cases, but in a small number of cases, a 0.2% incidence was seen occurring within 24 hours with a very, very high in-hospital mortality rate. So very important to think about that. It is feasible to perform PCI after TAVR, but it is challenging. You really should be in a center that has a really good ability with different and this one obviously would be, but it is frequent that patients are living longer now after TAVR, and we're going to be needing to perform PCI down down the line. And coronary engagement could be technically challenging, but I think we could certainly do this extremely well. And we published a paper in JACC that gave you a lot of tips and tricks on how to engage the coronaries after TAVR. It is important just kind of to think about this balance of aortic stenosis and CAD, and depending on what is heavily weighted, to think about how and when you should perform your TAVR. The timing should be adapted to the CAD severity, and the CAD PCI should also be adapted to the severity of aortic stenosis. TAVR is central to the treatment of patients with aortic stenosis, as you can see here, and depending on when you should be thinking about the CAD treatment has to do with the severity and the significance of the coronary artery disease and the patient's symptomatic issues that you need to deal with. There's an ongoing, lastly, I just want to tell you, there's an ongoing randomized study that's called activation study that's really trying to look at the PCI prior to TAVR implantation registry, but frankly, they've been going for a long, long period of time with very little enrollment. They are so far have really enrolled very few patients. It's going on for a long, long time, and what they're doing is trying to figure out what's best for the patient using these different risk parameters, but we will see when we can get these results. So to conclude, I think there's no question that we as interventionalists and the heart team group have to be with our surgical colleagues, have to work together in figuring out how to deal with patients who have concomitant CAD. This is prevalent, and we have to think about the complex CAD, especially in proximal artery of these patients. Often they're calcified, require high-risk procedural, high-risk PCI, and we think we have to really, really think about this. It's important that there have been important and good data that show how to proceed, but importantly, we have to think about this as a heart team approach and work together with our surgical colleagues and our allied healthcare professionals and everyone on the team to make a very, very good pathway decision tree for these very, very commonly associated diseases of aortic stenosis and coronary artery disease. Thank you so much for your attention.
Thank you, Dr. Mehran. That's very clear and very helpful.